Resume slideshow. How about now? Did they move to the second one, Omar?
Yes, it's on the second one.
We have time.
Okay, fair enough. So we talked about, we'll go quickly. So this was the key takeaways. We'll go back to them at the end. And this was the outline for the talk. And then we talked about the incidence of the cancer and the mortality of the cancer. We also talked, you heard me talking about this. Then we showed that patients with distant metastasis don't do well. And most of them die, unfortunately, within few years. Then we talked about the three different treatments that are available for metastatic disease, which is chemotherapy, anti-EGFR, and immune therapy in the form of immune checkpoint inhibitors. Then we started talking about the extreme trial. So you can see the extreme trial over right now, correct?
Yes.
Okay, very good. So for the extreme trial, we said this was chemotherapy. We said for the extreme trial, it was cetuximab plus chemotherapy versus chemotherapy only, and it was a positive trial in terms of overall survival in favor of the cetuximab with a gain of around 2.5 months, so 10.1 versus 7.4 months. And in the update of this trial in 2014, only very, very few patients were still alive after 5 years of enrolling on this trial. I think this trial is very important for a couple of reasons. From this study, we know what is the median overall survival for the chemotherapy. So in 2008, patients with distant metastasis disease, they would have lived on median for 7.4 months, whereas with cetuximab, this increased by 2.5 months up to 10.1 months. So this kind of put some benchmarks for survival for patients with distant metastasis. Okay. And this study also showed that it was not only a survival benefit, but also the response rate to treatment was better when cetuximab was added to chemotherapy. We can see that the cetuximab plus chemotherapy, the response here was 36 versus 20 for the chemotherapy only, and this was statistically different. So an odds ratio of 2 times higher, 200% higher in terms of response when cetuximab was added to chemotherapy. Very good. So as of now, the standard of care at that stage became the cetuximab plus chemotherapy per the extreme trial for patients with metastatic head and neck squamous cell cancer. And this continued to be the case until the landscape was challenged by the immune checkpoint inhibitors, by immunotherapy. And for immune therapy, the Keynote 048 trial was a very important trial. So this first-line immunotherapy trial was a randomized phase 3 trial with patients with recurrent metastatic head and neck cancer with any PD-L1 expression. So PD-L1 negative or positive patients were included. They should have been, not received previous treatment for the cancer, so it's a first-line treatment. And the primary endpoint for the study was overall survival and progression-free survival in the intention to treat population. Okay. Out of the patients enrolled on this study, 20% had laryngeal cancer, so similar percentage to what we saw at the extreme trial. It was 25% there. And the patients were randomized to receive whether pembrolizumab as a single agent immunotherapy, immune checkpoint inhibitor, or pembrolizumab with chemotherapy, cisplatin, carboplatin, or 5FU. And those were compared to the extreme regimen, so compared to cetuximab plus chemotherapy. Okay, so kind of comparing immunotherapy or immunotherapy with chemotherapy to cetuximab plus chemotherapy. And we learned a lot of things from this trial. This was a very important study. So for all PD-L1 patients, so that means all patients included in the study, we notice here that on the left side that pembrolizumab as a single agent compared to the extreme regimen, cetuximab plus chemotherapy, there was non-inferiority, meaning that pembrolizumab was not inferior as a single agent, was not inferior to the chemotherapy and cetuximab, okay? Whereas if we look at the chemotherapy plus pembro compared to the extreme regimen, there was a better overall survival. So all in all, this was a successful study in terms of meeting the endpoint of having better overall survival for the patients who received pembrolizumab plus chemotherapy and having non-inferiority for those who receive pembrolizumab single agent. But that doesn't, I mean, we need to dig a little bit deeper at that. So let's take a little bit more look into the patients who received the single agent immunotherapy, the pembrolizumab. In this slide, we are looking at the patients who received single agent pembro, comparing them to the extreme trial regimen. And you can see here that for patients with PD-L1 CPS of more than or equal to 1, and on the right side, we have those with PD-L1 CPS score more than or equal to 20. We see that the higher the PD-L1, like when it is on, when we only include those with CPS more than 20, the benefit from immunotherapy was more noticeable compared to when we include the patients with a lower PD-L1. So the hazard ratio here was 0.6, whereas here it was 0.7. So what that means is that when you are using pembrolizumab as a single agent, patients with higher PD-L1 will have better overall survival compared to patients with lower PD-L1. And we will look into that into more details. Now, if we look at the other patients, those who received pembrolizumab plus chemotherapy compared to the extreme trial, we see that the curves, whether the CPS score is 1 or more or 20 or more, the curves are pretty much similar in terms of the benefit from the combination of pembro and chemo. So the hazard ratio for both is around 0.6. So what that means is that when we are using pembro and chemo together, it seems that the impact of PD-L1 becomes less noticeable. So in other words, now it makes sense that if PD-L1 is low or PD-L1 is negative, that probably having the pembro and chemo together will be a better option than doing the pembro alone. And to look further into that, this is from the first publication of the Keynote-48 study. You can see on the left, those are the patients whose PD-L1 was 1 to 19. So we are kind of taking the patients with lower PD-L1 expression. And here we can see that for this patient population, when we looked at pembrolizumab as a single agent compared to the extreme study, there was no statistically significant difference, meaning that pembro as a single agent probably did not improve outcomes over the extreme study. Whereas when we look at the combination of immunotherapy and chemotherapy in this PD-L1 lower expression patients, the benefit from pembro and chemo is noticeable over the extreme study. So in summary, it seems that the lower the PD-L1, the more inclined as oncologists we will be to go with the combination treatment of immunotherapy and chemotherapy if the patient can tolerate chemotherapy. So this was very, very important to see and to point out from the Keynote-48 study. Another very important observation in the Keynote-48 is the PFS2. So as you see in these two figures here, it was noticed that for patients who progressed on the Keynote-48, meaning that they received the immunotherapy, whether as single agent or as immunotherapy or pembrolizumab with chemotherapy, once they progress and they receive the subsequent line of treatment, those who had received pembrolizumab early on, whether as single agent or with chemotherapy, had better response or better progression-free survival after the second line treatment. So in other words, it is to give immunotherapy, to give pembrolizumab as a first-line treatment, whether as a single agent or in combination with chemotherapy, seems to have an effect or a long-term effect that will still be noticed on the progression-free survival after receiving the subsequent line of treatment after progression. So this is the PFS2 benefit of giving first-line immunotherapy as a single agent or in combination with chemotherapy. All of these are important lessons from the Keynote 48, and probably the most important lesson is that on the 4-year for overall survival, there was clearly more patients who were alive, which was not the case with the patients who received chemotherapy with cetuximab only. So why do we get why do some patients respond to immunotherapy, others don't? Why patients respond for immunotherapy longer than others? It is no news that immune response to immunotherapy is a complex thing. So there are multiple pathways for resistance for immune therapy treatment, whether through the macrophages, the Tregs, interleukins, cytokines. There are all different types of resistance or methods of resistance to immunotherapy, and it is not totally understood. And probably another very important lesson that is, or another important point to make, which was described by Campbell and colleagues, that probably squamous cell cancer in the different organs is not created equal, meaning that squamous cell cancer of the lung is different from squamous cell cancer of the head and neck. And we can see that through the gene expression profiles and the microRNAs and stuff. So these squamous cells, although they are all called squamous cells, they are different in different body parts. Definitely in the head and neck area, the squamous cell cancer is probably more immune suppressive, probably compared to other areas. I treat lung cancer too, and the responses in non-small cell lung cancer squamous cell is definitely more noticeable than what we see in the head and neck area and the metastatic laryngeal cancer. So how to predict response to immune therapy? So far, what we have is the PD-L1, and we talked about PD-L1, right? We said that the higher PD-L1, probably the better the response to single-agent immunotherapy or single-agent pembrolizumab. But PD-L1 as a single biomarker or as the only biomarker is not sufficient to predict all responses or respondents or non-respondents to immunotherapy. It is probably a combination of other biomarkers that will be put together to better predict who will respond or not. In these two systematic reviews and meta-analysis, one in 2019 and the other one in 2023, you can see that the ROC curve is definitely better when we are looking at some sort of combinations like immunohistochemistry and immunofluorescence, rather than, for example, looking at PD-L1 alone. Now, what is the best biomarker or the best biomarkers combination to start use? We don't have anything practical or like standard of care to use right now, but I expect with time we will understand better what is the best combination biomarker for predicting response to immunotherapy. And on the right side, we can see the same here, that the combination biomarkers, again, immunohistochemistry, immunofluorescence of some sort, were better predicting responses than the individual biomarkers here, including the individual PD-L1 biomarker. Great. So that was for first line. So we said first line, we had the extreme trials, cetuximab plus chemotherapy that took over the chemotherapy only treatment. Then the immunotherapy or the immunotherapy pembrolizumab with chemotherapy took over the extreme trial as it showed a better survival benefit. Now going into the second line treatment, immunotherapy is still the best treatment if not given in the first line. As we expect, we will see less and less of that because now immunotherapy is approved as a first line and it is often used as a first line treatment, but it started in the second line setting. So the Checkmate 141 and the Keynote 40, they both tested the Nivo. The first one tested Nivo versus chemotherapy. The second one tested pembrolizumab versus chemotherapy. And the survival benefit was around 2 months for almost both of them. And here we look at the survival curves. So immunotherapy, this just gives an idea that immunotherapy, whether given as a first line or second line treatment, did better in terms of survival compared to chemotherapy. But as we showed earlier, that giving it in the first line setting is probably the way to go, given the long-term benefit of immunotherapy even after progression on the first line treatment. So, but as a second line, if immunotherapy is not given as a first line, immunotherapy is a second line treatment for recurrent metastatic laryngeal cancer. The other treatment option is the cetuximab. So cetuximab, whether in the form of the extreme trial, which probably is going to be the subsequent line of treatment, especially if the patient received only pembrolizumab in the first line setting. So the extreme trial will be an option, or to go into some sort of single agents or cetuximab combinations. This paper by Vermorken here, it compared three different cetuximab containing regimens of trials, like phase 2 trials, with some retrospective studies that use chemotherapies, pretty much to show that the combinations or whether cetuximab as a monotherapy or combination with other chemotherapies is probably better than giving chemotherapy only, with an expected overall response rate of 10 to 13% for the cetuximab containing regimens, and a median overall survival of 5 to 6 months. So numbers are small here, and the survival figures are not as impressive, but probably this is better than going with chemotherapy only without the cetuximab. So a cetuximab containing regimen as a second line treatment after immunotherapy will be probably the best option available right now. Then after progressing on all these modalities, we are left with single agents to use. I just have this from the NCCN guidelines just to highlight what are the possible treatments that can be used as single agents for subsequent lines of treatments without having large randomized trials to show that any of them is better than the other. To summarize the numbers that we talked about, it's good to put it in one slide. So these are survival benchmarks here. And I want to bring your attention to the median overall survival number in months here. So as you see, between chemo as a first-line treatment, between chemotherapy as the treatment of choice, the survival median was 7 months. Then we moved into the extreme cetuximab plus chemo, and we had 11 months for median overall survival. And with chemotherapy, it's up to 15. So this is doubled. So over the last 20 years or so, the median overall survival doubled through introducing the cetuximab and subsequently the immunotherapy. Very nice achievement, but we need to see more, especially that the 5-year survival is still very small. So we are talking with the first line immunotherapy plus minus chemo, we're still talking about like percentages, like single digit percentages, 5% 5-year survival or so. Definitely there is more room to improve the outcomes here. And in the second line setting, we can see second line chemo, second line cetuximab, second line IO. The numbers are very small in terms of median overall survival. So our best luck is to move with better first line and subsequent lines of treatments for recurrent or metastatic laryngeal head and neck cancer. So these numbers are for laryngeal cancer and for head and neck cancer in general. Very good. So what are the exciting new advances and new frontiers in laryngeal cancer treatment? So a lot of ADCs are out there. So these are drugs that attach to a specific antigen that is expected to be more expressed on the head and neck cancer cells. CD44V6, CD142, and others that are listed there are target antigens. And on the right side, you see the water flow plots there, and anything below the line is response. So you can see that on these like phase 1, phase 2 trials with all these different modalities or new molecules and drugs, there are some very promising, exciting responses. I hope this will translate into survival benefit for the patients on the more advanced clinical trials. The response rate has been, measured between 10% and 32%. However, there are some significant peculiar toxicities. So as long as we try to advance how these drugs improve survival and outcomes for these patients, we truly need to be aware of the toxicities that come with it and also to improve them. I think the field is moving very nicely in this area, and we will see some exciting new drugs come out in terms of ADCs. The other category to talk about is the bispecifics and the fusion proteins, and those are molecules that will attach, or antibodies that will attach to two different antigens. For example, there are drugs that attach to EGFR and LGR5 and EGFR and TGF beta. And again, you can see the water flow plots here, some exciting responses on the early phase trials. Hopefully we see more and more advanced trials that translate that into survival benefit. Very good. So to go back now to the key elements I wanted to, I started with. So the core treatments for recurrent metastatic laryngeal cancer are immunotherapy, cetuximab, and chemotherapy. And we went over the trials that brought those treatments to light. The higher the PD-L1 expression, the better the response to specifically pembrolizumab, as we said in the KEYNOTE-48 trial. And it is even more important for patients who will receive single agent pembrolizumab. New biomarkers are definitely needed. It is likely going to be a combination of biomarkers, as we said, to predict, to know who will respond to immunotherapy and who will not. New novel agents / combination treatments are promising. We look forward to see more and more coming out of that, and more advanced clinical trials, as mentioned earlier. And thank you very much.
Thank you, Dr. Taher, for your excellent presentation. So I have two questions. Any role for liquid biopsy or biomarkers in patients who develop local recurrence or distant metastasis?
We don't have much strong data on liquid biopsy in head and neck cancer yet. And probably part of that comes down to also that we don't have a true driver mutations in head and neck cancer, whether laryngeal cancer or other head and neck cancers, like we do, for example, in lung cancer. In lung cancer, the liquid biopsy is now well established as a way to look into specific targetable mutations or for resistance to actual treatments or like specific targeted treatments. We don't have that in head and neck cancer yet. Maybe with time we will see some about that, especially in terms of resistance. So if someone is receiving, for example, immunotherapy, then they progress, to do a liquid biopsy to find out why they progressed. That might come down the road. But as of now, we don't have a well-established role for liquid biopsy in head and neck squamous cell cancer. It would still be under research.
So hopefully we will learn about it in the near future. My another question, would you continue immunotherapy beyond progression?
Very good question. Usually not. If there is a true progression, we know there is pseudo progression with immunotherapy too, which is not as common in head and neck cancer, not as common in lung cancer. Only it's more common in other cancers like renal cell, like melanomas. So for a couple of reasons, if the patients progress in head and neck cancer with the critical location of, for example, if there is local recurrence and there is progression there is no room to really consider a continuing treatment beyond progression, hoping things will improve, when if they don't improve, there will be catastrophic results because of where the location of the tumor is. That's number one. Number two, we don't have real well-established studies to tell us that continuing beyond progression truly makes a difference. And for example, if you are giving as a first-line treatment pembrolizumab plus chemotherapy and there is progression, so you need to switch to something else. What would be that something else? It's going to be cetuximab containing treatment in a way or another. So to combine cetuximab with immunotherapy at this stage, this was done. Cetuximab and pembrolizumab were looked at into a phase 2 trial, but not to the extent that I would go into combining, for example, cetuximab with immunotherapy just to continue immunotherapy beyond progression. So the short answer is no. If there is progression, there is progression. I try to switch to another line of treatment.
So unfortunately, we have a limited number of lines in head and neck cancer, not like other cancers. So we don't have that much treatment options with systematic therapy, right?
I agree.
Yeah.
I think the single agents that we talked about, they are there, but they probably don't do much. I think the studies that I showed about, or like the quick slide I showed about the ADCs, the bispecifics, these are very interesting responses. When you talk about a 30% response rate for some of those ADCs in patients who are heavily pretreated, this is very promising. So I expect in the next few years, we will have more options to treat these patients.
Thank you, Dr. Taher, for being with us today. And